Okay, so welcome to today's Navigator Training Focus Series, Navigating and Engaging Community Resource. And we have a special guest, one of the founding members of CA Bridge, Josh Luftig, our wonderful harm reduction expert. So we have so much. So let's get started, you guys. I'm Sherry Cisneros. I am the California Bridge Navigator Program Director. So I'm in charge of all things and lead the team, all things navigation. We are a part of Public Health Institute, and we share all of our materials through Creative Commons, and you will get a copy of the resources used today and of the slide deck and the recording. So our housekeeping, please make sure that biggest thing here, highlight questions. Make sure it's addressed to everyone. We really want you to put your questions in the chat, and we do have our Navigator team and our CA Bridge team that will answer those if they can. And we just want to make sure that it is addressed to everyone, because if you have that question, somebody might else have it. So please make sure. I like to start all of our trainings with a thank you to all of our navigators out there. You are promoting 24/7 access to high quality treatment of all substance use disorders. You know, our big focus was opioid use and buprenorphine, but so many of you, from what we hear in our check-ins, are doing alcohol and meth, and it's great to hear it, because you know what? We will take them and anybody who needs help and support. So I love that your navigators are doing that. As usual, we always review our bridge model. This is the standard of care, low barrier treatment. That's what your physicians, your nurse practitioners, your PAs, they're administering low barrier treatment. Patient comes in, says I'm in withdrawal. Guess what? We give them buprenorphine, right? Or whatever other medication assisted treatment for their substance use. That's what the docs are doing. The last two focuses and pillars of our success is you, connecting them to care in the community and a culture of harm reduction. And we're going to talk about the last two today. So we have some announcements. We always like to announce our next, coming in the new year, January, we're going to have a wonderful speaker, Dr. Nola Vizi, about navigating cultural biases. This is not your typical cultural diversity class. She comes with a great background, and she's a wonderful speaker. So I highly recommend. We fell in love with her when we saw her. So these are our objectives today for those with CEUs. These are our objectives. We hope you understand, verbalize strategies, network with local harm reduction. So we're going to give you all of these answers in a bit. So before I hand it off to Latoya and Chaya, I do want to take a quick poll. Aiden, if you can bring up that poll. Okay, do you collaborate with your local community resources? We want to know, we're going to give you a minute. Frequently, that means once a week. Sometimes that means once a month, or you're just starting and not at this time. There's no right or wrong answer. We just want to know what are you guys doing out there for your community resources? We know there's a lot of different types and kinds, and we just want you to know. We want to know. We're curious, so we'll give you a minute. And we'll get the answer in just a second. All right, is this poll closed, Aiden? Let's see. So you guys are doing it weekly. That's the majority. That's awesome. That is awesome. That means you're really part of the community. Sometimes monthly, 33. I love this. Not at this time, and not a problem. We know things take time, and community resources are hard to get connected with. So thank you. I love this. Thank you very much. I just want to thank you for being here today, and I'm going to hand it off. Latoya and Chaya have some best practices for community outreach and engagement, and I'm going to hand it over to them. Latoya?
Hi. So what I would like to start with is the best practices. So we've talked many times about meeting patients where they are. That is actually really important. And the role of the navigator is not necessarily to talk patients into treatment, but it's to support where they are in that process of sometimes even just accepting the conversation with you, right? And then maybe accepting some resources. And sometimes that might look like treatment, sometimes it might look like other resources. But ultimately, you're planting the seed, so to speak. So when you're doing that and you build that rapport with patients, you're able to learn a lot about that person and their needs. And you'll learn pretty early on that they have needs other than just treatment. So being able to build up those resources is really important. They might have basic needs like getting a warm meal, somewhere to shower, clothing. It might be things like a primary care appointment, connection to mental health, or even linkage to tribal health or their local tribal communities. Your success as a navigator really does depend on having these resources at your fingertips to support patients when these needs arise. And so, what does that look like in terms of best practices? You may have heard the term of boots on the ground. What that means is putting things to action. So, very, very simple. Actually going and physically doing the work, which we just saw from that poll, many of you navigators are doing. But it's super important to physically visit these organizations or entities. You want to visit as many of them as possible so that you can build your rapport with those establishments and look at things through the lens of the patient. What does it look like when I first walk through the doors? Is it a nice, warm, fuzzy feeling, or does it kind of feel stagnant and sterile? You want to take note of those things. You want to meet with somebody that can specifically help you navigate those appointments, find out if they take walk-ins, learn who those main contacts are so that, and before they're called backdoor contacts. So find out who that person is that you can figure out how to get them in kind of essentially through the back door, and, alleviate a lot of the hardships and barriers that our patients see. Find out what kind of insurance they take and if they have a sponsorship program, especially for patients who are undocumented, uninsured, or underinsured. Find out if they cater to the most common languages spoken in your community. That might be Spanish, it might be Tagalog, it might be some other language, but find out what they cater to depending on what's in your community. And then gather as many of their brochures and flyers as possible so that you can take them back to your hospital and develop a resource index for your patients. Make sure to take your business cards and brochures as well so that you can leave them there for them to contact you and for them to give to patients if they need to refer them to you and your services. Sometimes they might come across patients who have needs beyond what they're able to serve, and they can route them to you. So it's a really great kind of back and forth relationship. And then lastly, you want to practice warmly handing off the patient with that community resource. So that might look something like this. You would call up I'm going to say the center. So, hi, Susan, I have John here who needs XYZ resources. Can you schedule him an appointment? Susan's like, great, Latoya, I'll get you taken care of. He can come in this day, this time. So then I go to the patient. I'm like, hey, John, I just spoke with Susan. She has you scheduled for this day, this time. I wrote it all down for you. Make sure that when you go in, you ask for Susan and she'll get you taken care of. And then I make sure to say, John, here is the local needle exchange information so that you can get the things that you need. And then here's my number. call me, check in, let me know how you're doing. I'm part of your support system now. Reach out if you have any questions or if something just doesn't go right, let me know. I don't mind. In fact, I love to hear outcomes and how you're doing with things. And then that's it. Uh, that's essentially getting out there and putting yourself in the community to build those relationships for those resources that our patients need, and then having that conversation with the patient so that they understand how to access the resources that you've helped cultivate for them. So thank you for listening to me, and I'm going to go ahead and pass it off to Chaya.
Hi everyone. Hi. Good afternoon. So I am gonna go over on how to expand on your outreach to local harm reduction resources. Who can you connect with? Latoya already have reviewed that a little bit, but you are going to want to invest your time in doing community outreach. And what does investing your time mean? With your supervisor approval, of course, you want to set aside a day, maybe a week or every 2 weeks, 1 to 2 hours to go out to the community, share about your services and vice versa, learn about the services that are out there. We have heard of a few navigators mentioning that they still don't have the naloxone distribution yet in their hospitals or don't know where to start for harm reduction. Go and actually find and actually go in person so you get to know your local harm reduction and your needle exchange programs in your area. My local needle exchange here is literally on a bus, and they offer naloxone, fentanyl test strips, and they just started telehealth for buprenorphine treatment, which is like super awesome. Also, one of our mentors, Zenia, she uses her naloxone with her, she shares that with her local harm reduction program for fentanyl test strips. So those are ways that you can save your hospital some money too. Another great way to meet different organizations is join your local opioid coalition and then expand to the national coalitions such as COPAN and OPEN. Something really cool recently, my local opioid coalition sponsored a pod meeting for us. And they even use some of their own fundings to purchase swag items for us. Again, another great connection we have right there. You're going to want to check in with your local county public health or behavioral health department and see what they are offering. They may have naloxone on top of treatment for HIV and syphilis, especially for those of you who are part of the DESP grant. That's something that Fresno County is already offering too. So like I said, I'm super lucky. Another county we found, Kern, has vending machines that offer the naloxone on top of hygiene products. And then you should definitely collaborate with first responders, such as EMS, police, and fire. They may be doing community education already on substance use and overdose prevention, and they will definitely benefit from you, an expert, and what you can offer at the hospital. So don't work in silo, work as a community, because you will reach so many more patients that way. There are still telehealth services available that is offering harm reduction. There's a harm reduction clinic in Yolo County that offers free naloxone training virtually once a month. And they've extended you a free naloxone in the mail if you give them an address. And then you definitely go out and check with your NAMI chapter and see what services they offer locally. Most NAMIs can offer free navigation to harm reduction in person and virtually. And then one last tip that I want to share is that you want to stay connected with another local or nearby navigator. Participate in the local county pods hosted by our mentors whether that's in person or virtually, and you will and find your navigator friend that way. It's like a great way to have a partner who can relate to you, especially about work. You can share resources and do outreach together. So that is all for me. Now I'll pass it back to Sherry.
Well, thank you, Chaya. Thank you, Latoya. Great information. So I want to pass off to our special guest, Josh. Thank you so much for joining us. We really appreciate it. Josh is the director for California Bridge for Harm Reduction. He is also a founding member of CA Bridge. So it's an honor to have you here, Josh. I'm going to pass it off and I'm going to let you share your screen.
Okay. Okay, how's that? Is that looking
Perfect.
correct?
It looks
Okay.
perfect.
Okay, great. Just missed that. Okay. See if I can advance. There we go. Okay, this is me. Thanks for the introduction. We're going to talk about next level naloxone and why the ED and hospital are such a great place for distributing naloxone. Of all the places that you could choose for naloxone distribution, why is the ED special? And part of the reason is it's a place that concentrates people at very high risk for overdose. It's a natural selection process where the more high your risk is, the more likely you are to end up in the emergency department as life beats you down. If you're having chaotic substance use, you're going much more likely to end up in the ED. And the ED is likely to be the only place that you're accessing healthcare. So this is an enriched population that we have direct access to. And the other thing is when you overdose, that's where you end up. So you end up in the ED after an overdose, and we're, of course, thrilled when we reverse someone with naloxone in the field and in the emergency department, but we often forget the step of giving naloxone out from the ED. And we know that that first 48 hours status post a non-fatal overdose is incredibly high mortality risk. And that's represented by this blue bar, this first line here of the mortality risk after an overdose. All that mortality risk is concentrated in that first 48 hours. So we want to make sure that everyone after an overdose has a kit in hand when they walk out of the emergency department. Prescribing has been a strategy that's been widely adopted of co-prescribing naloxone and prescribing naloxone in general. And the problem is that the people who really would benefit from having naloxone, only 11% are actually receiving a prescription. And the people at risk for overdose, only 1.6% are actually filling those prescriptions. So it's really a failed strategy. There's so many barriers between copays, transportation issues, stigma encountered at the pharmacy, on and on and on. All those add up to a system that we're having over 98% not penetrating the target group that we need to get these kits in their hands. The other thing is when you go in the community and you ask around, where can you get naloxone? You just ask a random person, where would you get free naloxone? Most people have no idea. Like, it's just not, like, I think I would go to the pharmacy, or I'm not sure. Like, they kind of just draw a blank. There's not a clear identified place in the community that can provide that. And the ED is already serving as a community safety net. So people do associate the ED as like, well, if I don't know where to go and I have a problem that needs immediate care, I have an immediate need, I go to the ER. So we can leverage that association with the access to naloxone. And we're able to provide safe 24-hour access, which is phenomenal. Like, most places just don't have, they're not open 24/7. And some of our environments are not that safe at night. So the ED is always safe and always open. And again, high-risk individuals access care in the ED. Often that's where they only receive health care, and that's where they go after an overdose. And it's a wealth of co-located resources. So you have, now that we have the bridge program, it's also a place that while you're getting naloxone, if you're starting to build in the behavior where you're getting your free naloxone from the ED, one of those visits to the ED just to the, say, to the lobby, to the, depending on how you're getting, how your program is set up, you may have a vending machine in your lobby, and that may be the only place that people are getting naloxone in their community. But eventually they may want to just check in and get help for their use disorder. And the ED also has, you know, it's the front door of healthcare. So you have access to all primary care, all specialty care. It's all right there through the ED. We can do Hep C and STI and wound care treatment, and we have social work and shelter referral. It's really become a hub for social services that are delivered. Community social services are, the ED is becoming the front door for those services as well. And it really communicates to the people who use drugs that this hospital gets it. So it really sends a harm reduction message to the community. If you walk in the door and you see all kinds of signage related to naloxone, you see, like I said, a vending machine in the lobby, or you're in the patient, you're being in the patient exam area and someone offers you a naloxone kit, like that's really a powerful message, a powerful harm reduction message, and a message that makes you feel like you can disclose your use disorder and you will receive practical and um, compassionate care in that setting. So you're more likely to disclose your use disorder and really have a therapeutic engagement rather than keeping your use disorder hidden and having an antagonistic relationship that's developed over, decades, historically between the population that uses drugs and is highest at risk and the healthcare system historically have an antagonistic relationship. And this really helps heal that relationship. And it works on both ends. So the staff, when they have a naloxone distribution program in the ED, it really changes attitudes among staff where they're starting to really get it. They're starting to actually participate in harm reduction, really understand treating people with dignity, providing what it means to provide practical solutions. All those things are starting to really soak into the staff that's participating in all that. So those attitudes are changing as well. And beyond just the ER, it's normalizing harm reduction in the community. So the hospital and the emergency department really sets the tone for the community. So, a lot of people are still kind of at step 1 or step 0 in terms of harm reduction. They're thinking that maybe naloxone would encourage drug use, which is not true. They're not really seeing the impact that naloxone can have in their community as a life-saving measure. If the local hospital really leans into it and publicly promotes this activity, it normalizes it for everyone. And so that other agencies, nonprofits, homeless service agencies, law enforcement, other people feel more comfortable moving into that space because it's been normalized by healthcare. And the ED can also model best practices. So if you have a system that is very low barrier, you can just walk in and just get naloxone without a lot of hassle, without giving any identifying information, if you can remain anonymous. Those types of features of your program can start to be adopted elsewhere in the community as a best practice. And they can be a catalyst for others to join the effort. We have great, the pictures on the last slide were some of our community partners. This is a list of 12 local community programs that began naloxone distribution as a result of our pilot site at Highland Hospital in Oakland doing our program. Because we started, then these 12 other adjacent community programs also started, which was an amazing ripple effect of our program. Let's talk about methods for distributing naloxone. So there's two kind of broad buckets for the ways that we're giving naloxone. One is direct in-hand distribution. So this is when, and this is what probably most sites are doing, which is as a substance use navigator, a nurse, a clinician, an ED tech, a security guard, even like really anyone, any staff member or volunteers can volunteer depending on how you've set out your program and how it's operating. But all those classifications of folks are giving in-hand distribution. They're handing it to a patient typically and ideally also any visitors and people at bedside. So family members and friends that are at the bedside are also being handed in-hand distribution by staff members and volunteers. And then you have automated distribution, which is going to be a distribution stand, a vending machine, or even a countertop basket type distribution method that's automated. And there's pros and cons of each. So if we think about in hand, we're thinking about it's very patient focused. Primarily, it's order set friendly, meaning I can build it into my EMR and have it be an order that we check off and we can track. So it's QI friendly. You can do quality measures and collect data on that and see how, are we getting after every overdose, does everyone, we can document that every single patient received a kit, or what's our metric, what's our target metric, and are we achieving that or not? So in hand is very good for that type of data collection and monitoring. It is staff dependent, so someone has to do it physically. It does require that resource of a staff person or multiple staff person if somebody's putting in an order and then someone's following an order to do it, if that's the model that you've set up. It is targeted and engaged, so it can start these great conversations that happen around, for instance, say someone who's using stimulants and is really not aware of fentanyl contamination. So you can say, I'm giving you naloxone now, and here's why it's so concerning with people who are using stimulants. I want you to stay safe, and here's the kit, and here's some more kits for your friends and family that may be using as well. So that type of engagement is really powerful. And then it can also help open the door for conversations around access to treatment. So, once you've had the buprenorphine, the naloxone conversation, that can be a door opener if we're talking about buprenorphine and methadone. It tends to be lower volume. So that is, you're not going to saturate the community by doing this in-hand method. So then moving over to the automated method, this is more community focused. So really thinking in the ED as a 24/7 harm reduction hub for your community. Tend to be higher volume with broader reach. So we're not just talking about patients who made it, who are, registered patients. We're talking about the entire community as a resource for your community. And it permits anonymous distribution. So we had our vending machines. Initially, we had them. And by vending machine, I'm not really talking about the newspaper stand style one in this instance, which is pictured. We had them initially in the lobby of the waiting room, the ED waiting room. And then we realized that some people might not be comfortable, standing in front of everyone and grabbing kits. So then we actually moved it into the front of the hospital. So you don't have to come in. You can drive up and just grab them or walk up. You don't even have to enter the building. And this type of model, this gets to where you can start to think about the saturation model, where we're really saturating, trying to provide enough naloxone that the community actually needs. So we're saturating that need. In order to support the automated piece and to make actually both the in-hand and the automated, both those models, in order to make them more viable and easier, we've developed a new workflow. So one, you can unlocked locations are definitely preferred and supported and well documented throughout the policy documents that you've are accessing through the guide to naloxone distribution on our website. And logging can occur with resupply of distribution points. So most people are thinking about logging as a per recipient logging, where you have these lines on the spreadsheet. There's an example log sheet on the right, and each row is like an individual, like how many kits did I give you on this date, and here's my initials. So instead of doing that, you can actually just log that you resupplied the ED charting room with 100 kits, 100 kits, the date, and your initials. So that really frees things up in terms of removing the administrative and documentation burden with this process. And that you can do that too with a vending machine. So you go to you're like, I put 100 kits in the distribution stand. That's another line. So that's just, you can each day or every other day, depending on how much naloxone is going out the door, every other day, you're accessing the log sheet once to just document your resupply. And then the other thing is that multiple methods multiple training methods are acceptable for meeting the training requirement. So um, our when we receive free naloxone, we have a requirement to provide training. But how we deliver that training is has evolved to become also very low barrier. And I'm going to go. You can do it in person, where we're basically, you're explaining how to use the kit. You can just the package instructions themselves, um, QR codes, and digital displays. And I'm actually going to go into this more in a further slide. In-hand distribution point locations. So the ED charting room, this is just some examples to trigger your imagination. So the charting room is so the dock box where often has like some cabinets or shelving that can be a repository of reserve naloxone. ED nursing stations. The intake is a great place to have it, like right at the intake and triage area. That way it can just be handed to people who are just in the waiting room who don't have to register. Or you can do it even just as in the intake process. It can just be given to someone. The fast track urgent care, a lot of patients go through that, those care settings, the less acute. That's a great place to have you can even, if it's a countertop in there, you can have it on a basket where people could grab it anonymously while they're, entering the care area. And then it also can be a place that staff can hand it to patients for the in-hand model of distribution as well. OBGYN, we have, the leading cause of maternal death is overdose, which is shocking. And we need to really target that area. So another way you can restock that area. So when you're talking about other out of ED partners, the way it can be framed is this program's run by the ED. I'm going to bring up 100 kits to OBGYN and I'm going to log it on my log sheet as signed out to OBGYN, and then they'll pass it out. They don't have to do additional logging beyond that. So it makes it really easy for your partners to participate in this program. And if they want to document it, which is for patients that are receiving it, so they have the option to give it to family, friends, and the patients as well. And they can always just put a little note that naloxone was distributed in the chart if they need to or want to. Internal medicine and the PACU. So PACU. So let's think about our post-surgical patients who are going to be, put on they just had a hip fracture and repair, and they are going to be put on a bunch of opioids heading out of the hospital. They should walk out with the naloxone kit as well. So really thinking about our surgery partners. Let's talk about two different types of quote unquote vending machines. One are the distribution boxes, and then the other are the vending machines. And I have pictures of each style. One is down on the left. For those of us who are back in the day when we had a lot of newspaper stands, these are basically the same thing. They're unlocked, steel bins that you just pull open the handle and grab as many as you'd like. And then the vending machine is a standard vending machine, like a beverage or snack vending machine, where you punch in a code and an item pops out. There's a split, they're very different in the way they what they offer. So a vending machine, a full-size vending machine can provide multiple items. So, and I think I have a slide. Yeah, we'll go through that in a sec. So, yeah, you can have all kinds of items in there. You can provide broad spectrum harm reduction. So beyond naloxone, you can, if your site is there, you can do fentanyl test strips. You can do safer sex kits. You can do safer use supplies as well. So gives you that flexibility to really expand what you're providing in terms of harm reduction. It's very visible. So that's great. Like, it gets a lot of people's imagination going when they see this big vending machine there. It can get your local newspaper interested. They tend to be really popular and just people gravitate to them. They talk about it. It really energizes your program. They allow remote inventory monitoring. So you can have, they connect via Wi-Fi or Ethernet. And then you can, it's like it just lets you know when it's running out of whatever supply. And you can also track how many of each item are going out. So you can have some data if you want to, write it up in a report to give to your own hospital or as part of research, however you want to do it. It's really good at capturing all that data. They cost way more. So they're going to be, we're talking about, 5 to 10 times more the cost to 20 times. It's sort of the sky's the limit. They have vending machines that will, provide telehealth right out of the vending machine. Um, and there's two different costs associated with them. One is the initial purchase price, and then two are ongoing maintenance costs. So there's a like a subscription model where you pay for back end support, ongoing incurring costs that can be thousands of dollars a year in costs. So that's I would say the biggest downside of the large vending machines. On the other end of the spectrum in terms of smaller size is the distribution stands. So they're gonna on the downside is you're gonna have limited items. Usually you would have, mainly just naloxone kits and plus minus fentanyl test strips. I think it's, fentanyl test strips can be tucked in there and they don't take up a lot of room at all. And it's a great value add to have both those items in there. They have a small footprint, which makes it nice. So you can have them scattered around. And you can move them. You can change your mind and move it, reposition it. It's not a big deal. One person can pick it up and move it. We haven't had people run off with them. If you're worried about that, they can be bolted to the ground, but we haven't needed to. And we're in downtown Oakland and no one has taken ours. But because they have that small footprint, for instance, I put 3 in. I have one in our ED, one in our dental waiting room, and one in our SUD clinic waiting room. So, and it was no big deal to put them in. It wasn't, there were less administrative barriers because it's just this little thing that you're putting in. It wasn't a big deal. Whereas putting in the vending machine, it was much more of a process to get that approved. It required a power supply, and our engineering department had to be involved with that. And we needed higher, much higher levels of administrative approval within the hospital to have that machine put into place. They don't require electricity. They have no temperature requirements, and they're very inexpensive. They run around $500 each, a little bit less than that, including shipping. The big vending machines, here's some of the items that can be stocked in those: fentanyl test strips, pregnancy test strips, socks are really popular. So this becomes sort of a social needs vending machine beyond just harm reduction. Drug disposal pouches, safer sex kits, personal hygiene kits that include toothbrush, toothpaste, and wipes. Feminine hygiene kits with tampons and pads, safer use supplies that can be syringe pipes, cookers, cotton, sterile water. So all those can be in there, and things that I'm not even thinking about or other people haven't thought about. But these are some of the really valuable resources for our vulnerable populations. And pregnancy tests have evolved, and maybe this is common knowledge, maybe it's not, but they've really there's these really inexpensive ones that look just like our fentanyl test strips. They're the same exact technology, and they look really similar, and they pack really small. So that's the latest version of the inexpensive pregnancy test strip. Where can you put your box locations? I think I mentioned the ones we use. I do recommend, if it's possible, to put them out front of your institution. It's just such a great community access point. It really advertises it and allows that anonymous distribution. It allows people to just, it's such a stigmatized condition. Many people who are at high risk just don't want to be seen getting naloxone. They want their privacy. So this gives them that privacy. Hallways, dental is another high value, like, a lot of opioid prescription, two things. A lot of opioid prescriptions originate in dental. And so, you have your tooth pulled and you're going to get, historically, and I think this is improving, but you often get these just massively large prescriptions for opioids after dental extractions or dental work. And then the other thing is the dentist beyond the ED, the place where people at really high risk come to contact healthcare, if they're not accessing healthcare at all, they're like, I never see my doctor. The only time they'll come in is if they are dragged in after an overdose or have a huge abscess and they go to the ED, or if they have horrible toothache, then they will go to the dentist. So those are really, really high value places to provide these distribution boxes. And of course, OBGYN, which you talked about. So the training. So the training can be, of course, in person, and that's great if you have, giving just, I like to, I can do it in about 30 seconds where I use the on-package instructions, which are that first slide where you can see it's just very clear the few steps involved in using the spray. And I just review those steps right with the patient in person. And that's great if that's available, if we have that time and that's the setting I'm doing an in-hand distribution. But also just the package instructions themselves qualify as meeting the training requirement. So you can just have the kits out in your box and that's it. Like the package instructions are fine for the training to meet that requirement. To really add a value add, you can apply these stickers. And on the right, you can see the stickers we're currently using, which show we have a QR code, and that QR code, you point your phone at it, and that links you to naloxone training, how to use the spray, and it also has all these other links that are in there. So the suicide hotline, how to get to your local syringe exchange, how to access treatment at our bridge clinic, where to get more free naloxone, the never use alone hotline, all that's in there. So you can really have the naloxone plus all these other features that you're giving when you provide this type of system. And I've set this up for basically the back end we use Bitly and a link tree, these are all just free accounts. Like none of this is costing me or the hospital anything other than a little time to set it up. Um, um, and then digital displays. Oh my gosh, these are great. So you can see in the upper center slide, or picture, we have a digital display. We have 3 of these in the hospital that are near the distribution stands. And they loop through, I basically run the CDC naloxone training video, and then I run it in Spanish. I just had it captioned, used an AI captioning service to recaption it, translate it to Spanish, and put captions on in Spanish. So it loops through in English, loops through in Spanish. I could put Chinese, I could put different languages in there. And then I also use that display screen for how to access our substance use navigators, how to access treatment. I talk about buprenorphine. I talk about long-acting injectable buprenorphine. I put whatever, I keep on changing it. And I just do that from my laptop at home. Again, I use free software. The screen itself costs $200 per screen. They're really inexpensive for a smart screen. This one in particular uses is Amazon Fire TV, uses that software. So I just download the app. That's a free app to run the software off my computer from home. Really great way to get a harm reduction message out there in training. For the automated distribution workflow, so it goes like this. You restock the self-service access points, and then you just report the number in the log sheet. So very simple logging process. And then the training is going to happen via the packaging or the QR codes or the digital screen. So that's how your whole system looks. The program basically runs itself. Very simple. And then let's talk about events. And I'm just always inspired by navigators who are participating in events. It's just fantastic outreach. And you can do it per recipient or per event. So meaning you can just say, 100 kits, you can just log out a 100 kits to your event, or you can, if you want to, you could log each person that received a kit. It's totally up to you. Overdose emergency wall cabinets. So these are great to have around your hospital. So like your AEDs or your tourniquet, stop the bleed kits that are mounted some places. Sites are starting to put up overdose emergency kits. So these can be little cabinets. They're inexpensive and wall mounted, and they can be across your campus. everywhere outside of the ED. The ED probably shouldn't have these because you have all kinds of naloxone right there in your Pyxis, and you have, when someone's actually in the emergency department itself, then you want to use your hospital supply of naloxone. But the DHCS supplied naloxone can be in these emergency kits outside of the emergency department, used in an emergency setting that's not, what somebody's, for instance, if someone's dropped, we have a lot of patients who are just dropped off at the front door, and we're rushing to get them in the ED. But in the meantime, while we're packaging them up, and sometimes there's multiple people, we can actually use a spray and quickly just administer naloxone while we're bringing them to the ED. Once they enter the ED, we're using our hospital supply naloxone. But in an emergency, we do what needs to be done to save a life. This is an issue that comes up a lot, a common question around distribution to minors. And the latest version of the DHCS guidance is that California has no statute requiring minors to obtain parental or guardian consent prior to receiving naloxone. Additionally, Civil Code 1714-22 indicates that naloxone may be distributed to family members, friends, or other persons in a position to assist a person at risk of suspected opioid-related overdose. So you have the state's support in giving minors 12 and up naloxone without parental or guardian consent. So that has been clarified, and that's the current guidance. So when you're applying for free naloxone, you now can use new templates. These have just been updated. So if you have not just downloaded as of this week the new set of templates and you have an old version, I would recommend with your next order to re-download templates and just fill them out the current version, because the current version covers distribution boxes, emergency wall cabinets, and vending machines are all now included in the new version of the standard operating procedure template. So your policy documents that you are required to submit when you apply for DHCS, and we provide those downloadable templates. Those are now up to date with everything that we talked about in this presentation. And also the training, the description of the training being just using the package instructions or a QR code or digital displays, all that has also been updated. And I think you're also aware that DHCS uses a NDP portal now, the naloxone distribution portal. There are no emailing in of, historically, we would just email everything to their email address. Now we go through their web portal. They're not accepting emailed applications anymore. But yeah, definitely use our quick templates. Sometimes there's confusion around, like, should we create our own naloxone policy at a hospital? Say you're a navigator who's helping set up this program with your champion, and there can be questions around, should we have a policy? You're welcome to draft your own policy, but the benefit of using our free templates is these have been pre-approved by the state of California. So anything that your hospital can rest assured they're doing what the other 200 hospitals in California are using, the exact same template that has been pre-approved by the state of California for this process. Everything has been signed off on. Unlocked storage, vending machines, all that's covered in these policy documents. So it's just the most conservative thing to do. That is where generally administrators want to be conservative. They want to stay in bounds, stay in the lines. And the way to do that is you just follow the same standard template. Reporting reversals. So when you are applying, you will hit a point where they will say, do you know how many reversals that your last time you applied? This is when you reapply. When you reapply, they want to know for the last batch of naloxone that you received, how many reversals were reported. And you're expected to report that back to the state. So you have two options. One is you can estimate your reversals, which is what we do. So LA County uses a 20% estimated reversal rate. So if they give out 100 kits, they estimate that they estimate 20 reversals came from those kits. If they gave it 1,000 kits, they would say 200 reversals would be their estimated number. And so I write in, we estimate reversals to be, and then the number, which is basically the number that I received last time times 0.2. You can also say, I don't know. So you can just say, I don't know, in that where it asks for that, and that is also acceptable, and that will not impact your next order. This is really, they're just trying to capture as much data as they can to continue support for this, their own funding, and to, reflect back to taxpayers that their money is being well spent on this program. Expired naloxone is a question that also comes up a lot. It lasts nearly 30 years. There's great studies where they analyzed naloxone kits that have been sitting in like less than ideal conditions, like basically riding around in cop cars and ambulance rigs for 30 years, and they were still active. So please, 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 if your kits are expired before you distributed them, reach out to us and we will find a home for those kits. Do not dispose of those kits. Reach out to us and we'll make sure that something useful happens to those expired kits. And that's it. Thank you so much for joining me. And Sherry, back to you.
Thank you so much, Josh. That's amazing what you're doing at Highland. This is all such a role model for us all. So I'm sure you're going to get people to reach out. Any questions, you guys, do you have for Josh? His is the standard. He's setting the bar, especially with the vending machines, and I love the fentanyl test. Like, they can get so much. That's such a great role model to have. So we really appreciate you here. Will you come back and talk to us in February, Josh? I want to confirm you.
Yes, and I'm really excited to talk about, there's a lot of confusion around some of the new, like the 8 mg nasal spray, nalmefene, there's other agents, there's a 3 mg spray coming out. So like, which one do we choose? And so we're going to dive into that in February. I'm really excited.
All right. Well, thank you. Josh is such a big supporter of our navigators, and I thank you and Kai. Kaya is on our program team, and she's a project manager. So thank you both for being here, and we will see you in February. All right, we're gonna wrap this up, you guys. We did really good timing. Usually we're running over, so I'm really happy about that. Key takeaways: engage with community harm reduction, network with your local navigators, and review the new updated guide to naloxone distribution. It is on the CA Bridge website. If you have questions and answers, let us know. You can also type them in Slack if you're on that channel. We will be happy to forward to Josh. So just don't worry about your questions, because we're always available. And then back to school. If you guys are interested in more trainings, the Sun Training 101 10-session series is online. You get CEUs and you can just go on there anytime. It's all self modules. So you can start, restart, stop, restart. This is the QR code, and we really encourage you to log on. All courses are free. You can contact us at mentors@cabridge.org or on Slack. We're always here for you. This is your mentor team, and always reach out to us. We are here. You have a whole team. You're never alone. You're always supported. I know you may be on an island out there in your hospital, but you've got a whole team here, along with Josh and Kai and the program team. Again, I'm Sherry Cisneros. We thank you every day for what you do. We know you are battling stigma and reducing biases and promoting harm reduction, as well as helping our patients. We thank you very much. We're going to end a few minutes early, 3 minutes, and we're going to give you that time as a holiday present. So thank you again, and don't hesitate to reach out to us. I will stay on for another minute if you have a question, because I know there's lots of things coming in the chat. Anything we need to address? Let's see. I think a lot of thank yous, you guys. Well, you are welcome, and we're going to have Josh back. So no worries. If you don't have a question now, save it till February, and we'll see you back in February, Josh, and have a great holiday
right.
season. Bye,
Happy
guys.
holidays. Thank you.